much for being here on time. And wanted to just quickly run through the outline of today. We want to cover all the material that we had intended to cover, but we're going to get through the XLAP emergency urinary tract surgery, and then we'll move on to our case studies where we'll talk about avoiding urinary tract emergencies and then GDV management, which was held over from yesterday. So the last two sessions Ellie and I will do together. So I think what's really important if we want to be good surgeons is that we touch only the tissues we need to touch and the other tissues we leave alone, because it's about gentle tissue handling. Every time you handle tissues, you cause more inflammation and damage. We talked about the importance of controlling that. And so it's really important to understand your anatomy, because with good knowledge of anatomy, it's like a roadmap. The anatomy tells you where you need to go and where you shouldn't go. And when I do surgery, I'm thinking about one step at a time. The first lecture I gave, I talked about chunking a procedure. And very much that's how I perform surgery. I go from landmark to landmark, and I want to make sure I hit each step. Where we run into problems is where you're not sure of the anatomy, you keep going, and then now it all looks a bit funny, and you keep going, and now you're really in a bad way. And we say that mistakes multiply, they don't simply add. And so what's really important is to understand our anatomy. And I think in this first lecture, when we talk about an exploratory laparotomy, that's key. So if you want good visualization of the whole abdominal cavity, you need to make your incision from xiphoid to pubis. Now, not every abdominal surgery we open all this way, because not all of our surgeries are exploratory. So sometimes we're a bit more focused, but if it's a true exploratory surgery, then you need to go from xiphoid to pubis. You need to identify your linea alba really clearly. In fact, this is where some of the mistakes are made, even as simply as a poorly positioned patient. So the animal is twisted on the table. You cut through the skin, and you can't find the linea alba. Often this is positional. Take your time, because if you go in paramedian, then again you go through more muscle, it bleeds, you can't get access like you expected to. And that leads to frustration, and then you can't access the next step. So each step is important. Don't skip a step. If it doesn't look right, go backwards. Find your anatomy and then go forward. If it doesn't look right, you're probably in the wrong spot. If you're going into an abdomen of, for instance, these repeat offenders that have eaten foreign bodies multiple times, every time you go into the abdomen, you'll cause a little bit of scarring. And so this is an example here of where this dog had previous intestinal surgery. And what you can see is we've got adhesions from an intestinal loop to the body wall, right under where we want to make our incision. So if we're going to do repeat surgery, be very careful just simply when you enter that abdominal cavity. Now, to me, it doesn't matter the system that you want to examine things in terms of the order. What's important is that you're consistent every time you do it the same way, so we don't miss anything. We talked previously about a checklist. If you are not sure of what you want to do in that abdominal cavity, write a list of all the structures that you want to examine, because then you've got one less thing you have to remember in your head. And this is what I do, particularly from if I get a case from my medicine colleagues, they'll often write down the list. They want intestinal biopsy, they want duodenum, jejunum, ileum, they want stomach, they want spleen, they want liver. I write this all down. Sometimes I label the pots before surgery, and we make sure they're all filled, because it can be very simple but very frustrating if you forget to biopsy something that you wanted to biopsy. So write a list, write a checklist. And again, the approach, I'll show you how I go through it, but you can develop your own order and technique. There's no one right way, as long as you examine everything comprehensively. So the first thing I do when I get into the abdominal cavity, I see the omentum covers over everything. If I leave that in place, often I tear that up. It gets in the way, it gets twisted. So I gather it all up. I start at the caudal end, because remembering it's like a cape that comes off the greater omentum, so it goes forward and wraps around. So go to the caudalmost end and just gather that all up so it's not in your way. If you pick it up and have a look, in the deep leaf here, you'll get the best view of the left limb of the pancreas here. So you can check that. That's the first thing I have a look at. And then I just leave it all bunched up around the greater curvature of the stomach, and now I can get to all my intestines. We then look into the cranial abdomen. Now for this, I like to have balfour retractors holding sideways, And then I use a little handheld retractor. Here you can see this is a Langenbach retractor, but you can use any bladed retractor, and I use that to lift up the rib cage and pull things forward. Now, if you really need access to that cranial abdomen, you can in fact create a little pneumothorax. So you can make a little hole in the diaphragm and everything shifts a long, long way back. So if we're doing major liver surgery, create a little pneumothorax. It means you have to tell your anaesthetist because they'll have to ventilate the patient. But if you can't get to that area, if you've got a liver tumour and you can't access it, it's very hard working up under the rib cage. For an exploratory surgery, you don't need to do that. Normally just some retraction will help. But there's always a way to get to some part of the body. And where we go wrong is often when we have a little window of access. You can't see, you get some bleeding, mistakes multiply. To get good visualization in the cranial abdomen, I'm looking at the liver. I'm looking at all the lobes of the liver. I'm looking at the gallbladder. You can follow the gallbladder and you can find the common bile duct and when it inserts on the duodenum. So these are all the things I'm looking at in the cranial abdomen. Then I get my duodenum and I use the mesoduodenum to pull all of the intestinal loops to the midline and even over the midline. And that acts as a basket and it opens up the right paravertebral gutter. And so within the right paravertebral gutter, we'll see the right kidney and the adrenal gland, the right adrenal and the ureters. There's not much else that lives down in that paravertebral gutter. If you have hemorrhage after a spay, then this is the area that you'll look for bleeding. If we've got ovarian remnant syndrome, this is where we're going to look for those remnants. And so it's very easy to see. Within that mesoduodenum, you'll see the right limb of the pancreas. So we'll get a really nice look at that. So the pancreas, we've seen the left and the right limb now. Also, you'll see in this area here the portal vein and that epiploic foramen. So this is an area that we don't often go into, but that's what you'll see in that right paravertebral gutter. I then move caudally now, and now I'm looking at the bladder. I'm looking at the female reproductive tract and the male reproductive tract. So here, this is a pyometra. You can see the incision is relatively small. This is not exploratory surgery, this is focused. We already know the condition. Our aim here is to remove the uterus and the ovaries. Our aim is not to do a full exploratory. So in this case here, you'll see our incision is small. We're then going to move around and look at the left paravertebral gutter. Now what I grab here is the mesocolon, and I pull that to the right side. So again, I create this basket, which is held back by that mesocolon, and I pull it to the right, and that will allow me to see the left paravertebral gutter. Again, in here, left kidney, ureter, and also the ovary and the uterine horn. So again, if there's bleeding, this is where I'm looking. And then I'm going to run the GIT. And I think for many of us here, probably gastrointestinal disease is probably the most common cause why we're going into the abdominal cavity. So at this stage now I run the GIT. Because the GIT runs everywhere, I look through the fixed anatomy first and then I run the GIT. So I look at the stomach, I palpate the stomach for foreign body, for instance, leads me to the duodenum, and then I follow the duodenum down. Every inch of the intestine I run between my fingers, but what's important to minimize the risk of further damage to those intestines, because they're very delicate, I have a bowl of saline and I always have moistened hands. I don't want to have dry gloves when I'm touching anything within the abdominal cavity. So I simply have a bowl of sterile saline, I dip my fingers in like that, and then I work my way through. If I can feel my hands, creating more friction there, then I'll, again, moisten them with saline. That's really important to try and help keep those tissues healthy. Because every cell that dies during our surgery is another cell the body has to remove in the wound healing process. So we're trying to minimize contamination, we're trying to minimize damage to tissue. Another important thing is the more damaged the tissue is, the more susceptible it is to infection. So we want to be very gentle with all our handling. Now the problem I think many people face is you get the duodenum. Everyone can find the stomach. They can follow the duodenum down. And then if we look at this video, you follow the duodenum down, and then what happens is it disappears and it goes into this big heap of material. So often people get stuck there. And you go, well, what do I do now? Well, if we remember embryologically, the root of the mesentery had a twist in it. And so what I like to think of is the intestines making two question marks like this linked. So the duodenum comes down the right body wall, it curves caudally around the root of the mesentery before ascending. The colon does the opposite. So the colon starts on the right, and then it crosses across that root of the mesentery cranially, and it runs down the left body wall. So originally what happened is that you had two straight lines here, but then they gave a twist embryologically. So if you take all that massive intestine and move them cranially, then you will be able to follow that duodenum round around the caudal root of the mesentery until you see that duodenocolic ligament. That tells you you're all the way around. And this is not an uncommon area where things get stuck. So let's have a look at what that looks like. So first of all, we're going to see here, now we get down here and they go into this mass of intestines. Can't follow it any further. So what do? All right. Well, now what I want to do is I want to get all the intestines here, and I'm going to shift them cranially. So just gently bring them out. I've got moistened lap sponges to keep everything moist. We're going to move them cranially. And now we've moved them cranially. Look at this. We can follow that duodenum all the way around, and you can see where it joins onto the colon. The colon is here in my right hand, the duodenum in the left. So you can see now we can follow that round. And that's particularly important to know if you've got a linear foreign body, because you might not be able to sort of move things around very well. So get all the intestines, move them cranially, and that will allow you to see the caudal root of the mesentery, and then you'll just follow on. And then it's just a case of putting it through your fingers, but you should be able to touch in one continuous motion from stomach down to colon. And this is the way you won't miss anything. Because if you follow it one way, pick up the other end and follow it back, there's a possibility that you miss a bit right in the middle. So when we talk about biopsying, because many of the times when we do an exploratory surgery, it may be not because of an obstruction, but it may be because we want to biopsy because there's underlying disease. And so I talked yesterday about this movie, Free Solo. Hands up if you've seen it. My palms were so sweaty. Again, it's a great movie, won an Academy Award, but it's about this free climber who says what he does is low risk. I'm not quite so sure about that. He says it's more high consequence, which it really is. He's dead if he falls, but chances are he won't fall. And it's a bit like that with GIT biopsies. So the dehiscence rate in experienced hands is very low. I think it's important to recognise that the figures that are quoted here are not necessarily your figures, because it depends on who were performing these surgeries. Many of them come out of very big academic institutions with very experienced surgeons. So this may be aspirational, but it does tell us that the actual dehiscence rate is very low. So in the largest study of 126 biopsies, they had one dehiscence. But this is really important to communicate to owners, because there is the potential for harm to occur. So you've got to be able to justify why you want to take that biopsy. Very small chance that you may have a problem, but the consequence is high. It'll be a reoperation to manage a septic peritonitis if it does dehisce. So if we're talking about biopsying the stomach, now for me, I have these cases referred to me from our internal medicine department, often for chronic gastrointestinal disease. And so they want multiple areas of the gastrointestinal tract. So they'll often want stomach, duodenum, jejunum, and ileum, because different diseases can affect different parts of the intestine. So when it comes to stomach, we went through this yesterday, our approach to the stomach. It's very similar. Our setup involves having bowel flora retractors, 2 stay sutures thrown over to the side. Even though this might be just a biopsy and not a gastrotomy as such to remove a foreign body, I still set this up in much the same way. I have suction on hand to make sure that when I make my incision, I don't get spillage. I pack out that stomach. So all I'm looking at is the stomach itself. Remembering we cut through the seromuscular layer with a scalpel. If you go all the way through, that's no problem. But once I'm through that seromuscular layer, I want to identify that mucosa, submucosa layer, use my DeBakers to tent it up, make a little stab incision, and then extend it with scissors. You want to get all layers, generally, when you're biopsying. So then you can just trim out a little corner, a little edge of that before closing. And remembering we said the closing is in 2 layers. So we need well-maintained scissors, DeBakey forceps. Whenever you biopsy, you want good instruments because you don't want to crush the tissue. It's devastating if you go in, you go through this work, you send the sample to the pathologist and they say crush artifact, unable to give you the diagnosis. So you want to make sure you get a big enough piece, and in the stomach you can take a centimetre of tissue, it's not a problem. But you don't want to crush that, particularly if you're taking a small biopsy. So sharp instruments, closure in 2 layers. I like to close mucosa, submucosa, simple continuous, and then again appositional in the seromuscular layer. So same as a gastrotomy, nothing changes. Principles of surgery. You can invert that seromuscular layer, but it has no potential advantages over an appositional suture. When it comes to intestine, I showed you this slide yesterday. My setup for intestinal biopsies is the same as if I had a foreign body. So we want to exteriorize the loop here. We want to pack that out so we minimize contamination. I have a little syringe with that saline because once we have this tissue out of the body, probably within 1 minute, it'll start to look dry, particularly if you've got air conditioning in your theatre. So you need someone constantly dripping saline onto this site because if it's looking dry, that's dead tissue on that top layer. So we're going to drizzle it with saline. And the way I perform my biopsies is as follows, but you don't have to do it this way. What you want to do is you want to get a sample. It needs to be full thickness. It can't be crushed, and then you want to have it suitable for a very neat closure. So this is one technique, and this is the technique that I use. And I just take that 4O PDS material, so I have heaps of it, that's my favourite, on a taper needle. I take 1 bite here on the anti-mesenteric border, as you can see. But this allows me to create tension, because what you can see is I've got my assistants there holding that tissue. But if you're trying to cut with a scalpel blade and the tissue isn't under tension, the scalpel doesn't cut. So when you make a skin incision, you use your non-dominant hand to tense the skin as you run the scalpel blade along. Tension is really important when we're cutting with a scalpel blade. So I create tension by having this stay suture and pulling up on that. Now I have tension between that stay suture and my assistant's fingers, because it's fine if you've got them holding at either end here, but I want to cut and take out a piece. And so what I do then is I create a little V on either side of that stay suture. Now, little bits of tissue are hard to handle. And if you get even your DeBakey forceps and grab that tissue, you're likely to cause significant crushing. In this way, I don't actually handle my biopsy sample with my hands or with any instruments. It's just a sharp needle that's gone through. I make 1 incision down on one side like a V, and then we make the other incision on the other side like a V, and you can see here's my little fragment of tissue. It's full thickness that comes out. Then I have a look here and I can see down the bottom, you can see that's the mucosa, so I can check that I've got full thickness. You know your full thickness generally because stuff starts to want to come out of the hole. So you get a pretty good impression of that. But once you've got this little sample now, I can take it over to my assistant here. I take a pair of hemostats, and then like a meat skewer, and you're taking the meat off, I get my hemostats, I hold it over that formalin pot, and I just slide it off the suture, and it falls into the pot here. So this way I don't have to handle that tissue. It's very gentle, and we get minimal crush artifact, and there's no risk of it falling on the floor. And it means also I put my sample in the jar, not on the table, because things can get discarded. Don't put anything in a swab and leave it on the table. Someone will surely throw it away. So I put it straight into the formalin pot, and I label that. And then simply I'm closing this, generally 3 to 5 sutures. The mistake I see people make early is they make the V too deep. So it almost becomes like a resection anastomosis, and they might have 10 sutures in there. If you've got more than, say, 5 sutures, perhaps you've made your V a little bit too big. So other techniques include using a punch biopsy. Now, I find it a little bit hard to cut with these because I can't really control the tension. And so I don't use that, but I've certainly seen people do that. I've seen people make an enterotomy like you would for a foreign body, and then they get scissors and just trim off a little edge. That's another technique. Again, these are just ways of doing it, but if you've got a technique that works well for you, I wouldn't necessarily go changing it. What's important is you want a clean incision, you want minimal crushing of the tissues, and you want to be full thickness. Be mindful when you're biopsying intestine, often the tissue is thicker than you expect it to be. because it's disease. That's why you're biopsying. Remembering what we said, that closure 2 millimetre by 2 millimetre bites going in perpendicular. And what can happen is if you're too forceful and moving that knot around, you can tear through this delicate tissue. So as I'm tying this suture, I showed you this video yesterday, my focus is on keeping that knot in the same space, not pulling left or right, not pulling up or down. So I want to try and concentrate on keeping nice, even pressure. Where I've had problems, if I have a bad pair of needle drivers and they slip, that can pull that suture right out of there. So you want to be very careful. Okay, so that's intestine, stomach. Now what about lymph nodes? Well, the most commonly biopsied lymph nodes in the abdominal cavity, the mesenteric ones. But we've got to note that the mesenteric lymph nodes sit at the base of the jejunal vessels. So if you think of the lifeline to the intestines like a branching tree, the lymph nodes sit right down at the trunk of the tree. If you try and excise one of these lymph nodes, it's a high likelihood you'll damage the blood supply to the entire jejunum. And that can be horrific. So this is what's happened in this cat here. Excisional biopsy of one of these nodes, necrosis of the entire gastrointestinal tract. This animal was euthanized after a biopsy. What I would recommend you do is you simply dissect out one pole. So you just dissect out the end until it sits out a little bit like this. And you do that very gently. You stay on the node. It's very delicate. I then simply get a sharp blade and I cut the tip of that lymph node off. I don't suture that. I simply cut that off. You can put a suture in the peritoneum, but you don't need to suture it for hemostasis. But only do an incisional biopsy to one end of that mesenteric node. Do not take the whole node out, even though the pathologists will tell you, we love the whole node. Well, that's great for the pathologist, but you're the surgeon that has to live with the consequences. So you normally would just take a portion of that. So don't take the whole thing. Lymph node. All right, what about liver? We talked about the difficulty accessing the liver. We mentioned one technique is, again, to create a pneumothorax if you need access to the liver. Rarely is that needed for a biopsy. Normally with Balfours and a little Langenbach pulling cranially, you can get nice access. So access is rarely the issue here if we have a good setup. Hemorrhage is something everyone worries about. But again, just like the blood supply to the jejunum is a branching tree, same thing goes in the liver. So this corrosion cast shows you how small the vessels are in the periphery. So if you were taking just a peripheral sample, a couple of millimeters from the edge, it's unlikely you're going to get significant hemorrhage. Now, it can sometimes be frighteningly brisk when you first perform a biopsy. Bleeding's a bit like that. It gushes at first, your heart nearly stops. Be patient, put a bit of pressure, give it time. Because we are relying, though, on the body's own hemostatic mechanisms, I like to run a coagulation profile. Because remembering, a lot of these clotting factors, they're proteins, they're produced in the liver. You may be doing this because there's severe liver disease. So checking that their clotting is appropriate is a good idea before we go ahead and do this biopsy. But there's a couple of techniques that we can use. And the simplest one, the one I use probably 90% of the times, it's the guillotine technique. I place a little loop of suture over the very tip of one of the lobes, and then I crush all that tissue. The idea being that I'm grabbing the biggest vessels to ligate, and I'm just tearing through all those smaller vessels. I then get a pair of scissors and I just cut off that tip, or you can use a scalpel blade as such here. Now, there will be a little bit of oozing because the liver is parenchymatous. There will always be bleeding if you handle it. And so you can use a little gelatin sponge. You can see that sort of tucked up in here after a biopsy. So where are we? Here's my pointer. Here we go. So here's a little bit of a gelatin sponge here, and that can be used just to aid hemostasis. So the way this works is it just helps provide a bit of a scaffold for a blood clot to form. It's not magic, but it just provides a bit of pressure there. Because normally in the abdominal cavity, nothing wants to stick together. And so this will help. If you've got a lesion that isn't on the periphery, then the technique I like to use is, again, using this skin biopsy punch. Again, you could use varying sizes depending on how big the lesion is. But what this means is you can only go in about 1/2 centimetre because you can't push in further. So you're still on the periphery. Now these can bleed, as you can see here, but what I do is I get that gelatin sponge here. So gel foam is the product I use, and you can get that same skin biopsy punch and make a little tube here of that gelatin sponge, and you simply plug it into the gap, and that just helps it form a framework for a clot to form. An alternative is you get a little strip of it and you roll it into a little cigar and then stick it in that gap as well. Be gentle, because the more you handle it, the more it tears and the more it will bleed. So just initially, after you've taken that biopsy out, a little bit of pressure, a little bit of time. Get ready with your little plug here, and then just put the plug in. It's likely to still ooze a little bit. Just put a bit of pressure. Give it time. It takes about 2 minutes for these clots to form. Now, surgeons are very impatient, so you may have to tell your nurse, please put on a 2-minute timer, and don't let me do anything until that time is gone. The problem with hemostasis is generally you're touching it too much. Give it time. It gives you time to breathe. Cover it over. You don't even have to look at it. Bit of gentle pressure. And then for those of you who have laparoscopy, then you can certainly look at taking samples this way. Now, in this regard, and this should give you some comfort of the hemostatic effects that are occurring, is you just take a bite of tissue out of the periphery and let that stop bleeding on its own. So again, doing coagulation profiles is good. If you're taking out a bigger area, then we often will use a stapler and we'll remove a whole lobe. So the last one I wanted to talk about in terms of biopsying is the pancreas. So the pancreas, again, we said we can get to it here by looking at the deep leaf of the omentum for the right. We look in the mesoduodenum for the right. The left is in the deep leaf of the greater omentum. And this is lobulated. You've probably all had a look at the pancreas. You can handle the pancreas. You've just got to do it very gently. But remembering, this is an organ which produces a digestive enzyme. So we don't want leakage. So unlike the lymph node that we can just amputate a pole, here you want to do the guillotine technique. You want to seal off the ducts. So I just blunt dissect out one of the lobes. So for instance here we might look at taking out just this little lobe right here, for instance, that's sort of hanging off the end here. I might get a mosquito hemostat and just tear the peritoneum around it and just blunt dissect around it. And then the same as with the liver. Guillotine technique here, just put a little suture around the end and then snip off that little bit of pancreas. So you've just got to be gentle with the pancreas, but certainly you shouldn't be afraid to handle or touch it, but you've got to do that very gently. So again, this is often the shopping list. I write down all the biopsies that I want to take. Now, just quickly, I did want to talk about abdominal closure because I think this is important. This is an incisional hernia. This is what we're trying to avoid whenever we're closing the abdominal cavity. If you think the reason why you're biopsying is perhaps neoplasia, and this patient will go on to chemotherapy and have poor wound healing, I will sometimes close the abdominal wall using non-absorbable suture because we have seen dehiscence for animals that then go on to chemotherapy. So think about what your most likely diagnosis is. Non-absorbable suture may be preferable. Now, what's important is to recognize the strength-holding layer of the abdominal cavity is the external rectus sheath. It's not muscle. It's the rectus sheath. And it looks different at different levels of the abdominal wall. So proximally, you have a really nice linea alba. But as you move caudally, basically those two muscles of the rectus join together. And so you won't see a nice linea alba, but that's okay. We just want the external rectus sheath. About 6 to 8 millimeter bites from the edge in cats, probably 1 centimeter in most dogs. So again, watching here, what we're focusing on is just grabbing that external rectus sheath here. We don't want to grab a lot of muscle. If you grab muscle, you can't separate the two, that's okay, but I'm trying to get just that sheath here.
Okay, stop video.
And so I want you to look here. I've got an assistant keeping tension on that line. And if I can't find the layer I'm after, then I keep looking and I grab the layer that I want with my forceps. So watch here, you'll see there's fat. See on one side, there's a lot of fat there. So we can lift that away. Make sure you're holding the layer that you want. Again, on both sides like this. We've got our assistant here. I don't have a third hand. That's someone else's hand coming in here. There I can see the external rectus sheath. And then again, a little bit of fat is going to come into play here. So we use the needle to hold that out of the way, grab the layer we want. And this is so important. You want to take your time and make sure you're always getting the correct layer. Now again, these animals that you're biopsying are often diseased, so they may not be healing like you would expect a normal animal to. This is a little video that I made. This is a cadaver, but it shows you the strengths of the different layers. So have a look. This is fat. So pull out strength of fat.
This is pull out strength of fat.
Nothing. That makes sense, doesn't it? Fat doesn't have anything to hold on to. Essentially, it's the collagen content of the tissue that determines how strong it is. Very little collagen in fat. Let's look at muscle now. Okay. Intuitively, any non-vegetarian here knows there's not much pull-out strength. You look at that linear, though, and you can see, again, that's where all the strength is. So you want dense connective tissue. This is just a general surgical principle. Tissues with more collagen is where your strength holding is. And then I just wanted to show this example. This is how I close a sub-Q. And so again, the sub-Q, it contains fat, and within the fat is a very thin layer of muscle, the panniculus muscle. Within that layer is where all the collagen is in that subcutaneous tissue. So you don't want to suture just fat. So you don't want to suture this tissue here. So it's just loose. What I'm looking for is the layer just under the skin that moves the skin. That's where the collagen is. So when you're doing a sub-Q closure, if you grab that layer, it will support your skin closure. It will give you added wound strength. It will give you a much better cosmetic result too, because you're matching the layers. So sub-Q is not a single layer. There's a thin layer of sub-Q. Then there's muscle, and under that sits the subdermal plexus, or just above that sits the subdermal plexus, but that's a little muscular layer where all the collagen is, and then you've got a much bigger layer of fat again. So look for that layer. Next time you're in surgery, have a feel for that. See if when you grab that layer, the skin moves. But that's my check to make sure I've got the layer with the collagen in. So, take-home messages. Abdominal biopsies, low risk, high consequence. Make sure you're prepared. You've got your right instrumentations. You set yourself up before the biopsy. Just because it's small doesn't mean it's any less significant than a bigger incision. When it comes to bleeding, be patient, particularly with the liver. Don't keep handling the tissues because you're likely just to make things worse. So bleeding will stop. All bleeding will stop. Generally, that pressure and time, taking a deep breath, is certainly a thing I would look at doing with when you're frustrated with the liver continuing to ooze. All right, thank you very much. Now, I wanted to move on to urinary